Hi, everyone. We might make a start. Um, Welcome to another Common Sense Oncology Journal Club. My name is Demi Karikios. I'm a medical oncologist working in Western Sydney in the Penn Hospital. We've got an excellent talk tonight. But before I get into introducing Abi and his talk, just briefly, I might remind people who are new to Common Sense Oncology or have not heard of much about it before what Common Sense Oncology is about. So as many of you might know, Common Sense Oncology is a group that formed a few years ago, really with the main mission of ensuring that we put cancer care back to patients and really focus on outcomes that matter to patients. So our vision overall is to really have patients have access to cancer treatments that provide meaningful improvements in outcomes that matter, irrespective of where they live or their health system. And that vision is really pertinent tonight's talk. As we all know, sometimes clinical trial access isn't equitable. Before I introduce Abi, I just wanted to point out there'll be definitely an opportunity to ask questions tonight. So we'll have some discussion at the end of the talk. I'd really appreciate if you put your questions in the chat, if you have questions that come up along the way, because I'll happily read them out. But similarly, at the end of the talk, feel free to turn your cameras on, mics on, and ask questions. Maybe just use the hand up function so I can address you. So let me introduce my very good friend Abi, and excuse me while I show him off for a minute because I'm quite proud of Abi. So I'm going to read his bio so you all know how much of an awesome dude he is. So Abi's a medical oncologist as well. It's actually Prof Abhijit Pal. He's with a clinical focus on lung cancer and early phase clinical trials, and he's worked as a consultant oncologist in Southwest Sydney for a number of years now, and he serves as socially and culturally and linguistically diverse part of Sydney. He completed a PhD through the University of Sydney, supervised by Fran Boyle and myself, and that's why I'm quite proud. And he got awarded that in 2024, and really was about informed consent for early phase trials and improving equity in clinical trial access. So he's a great speaker for tonight. Abi's an active clinical researcher. He's a key member of the newly formed Australian Centre for Cancer Equity and leads multiple community-based research initiatives with those communities. He's prolific in publication. He's published 35 papers and has $6 million of competitive grant funding that he's achieved. He's also recently joined trials as an associate editor. Most recently, Abi's got an award for his excellent work. So he was awarded the 2025 Improving Equitable Outcomes Award at the annual Cancer Institute New South Wales Premiers Awards. So without further ado, I'd love to introduce Abi to give us his excellent talk tonight on improving clinical trial access for culturally and linguistically diverse individuals. Thanks, Abi.
Thanks so much, Demi, and thanks for that kind introduction. And thank you all online right now. And if you listen to this as a recording, for joining this webinar. I'm really hopeful that you will find something of interest to take back to whichever setting you work in, and perhaps some collaboration as well. So just first like to acknowledge country since I'm in Australia. So I'm going to pay respect to all elders, past and present, and celebrate the diversity of Aboriginal and Torres Strait Islander people and their cultures and connections to the land wall of New South Wales. I guess I actually spoke to CSO and I said, I asked, where are the audience coming from? And it turned out 3/4 of tonight's registrants were from countries outside of Australia. So I'm in Australia, redback spiders, kangaroos, and koalas. I remember going to ASCO one time and they said, and this American said, spiders, right? Like there's much more than spiders here, but in Australia. And I work in New South Wales, which is the state down here. Just to give you an idea of this, easing into this idea, what is Australia? Now, who lives in Australia? Australia is now a majority migrant nation. So you can see here that the proportion of first generation Chinese and Indian is rising and reflects the waves of migration in the past decades with more Indian, more Chinese, more Vietnamese, and it's changing as well. So Australia is a migrant majority country. A lot of people, 2.7%, a lot of populations in Australia are not able to speak English as well. I'll go into that as well. So I guess takeaway, it's a migrant country, people speaking language other than English. I'm in New South Wales, which is one of the states of Australia, and I work, and New South Wales is a big country. So that's another thing about Australia, it's a very big country, and New South Wales is a big state, and I work in Sydney. And this is actually Sydney. And I think I put this up because this is going to become really focal as to where Australian Centre for Cancer Equity came from and why Southwestern Sydney is insignificant. But you can see here, I work in this red part here. so southwest Sydney, and this is eastern suburbs. And basically, there's a bit of a socioeconomic gradient as you go from the water to inland, and that goes from there. And you can see these are some of the areas of New South Wales with the highest proportion of population born overseas. You can see Auburn, for example, which is a part of New South Wales in Western Sydney LHD, which is a bit above me, 61% born overseas. Fairfield, which is part of my district, 56%. So Parramatta. So I guess you're all in different jurisdictions, but in many economies, there are pockets of significant migrant communities, and that's the same in New South Wales. So I work in southwestern Sydney LHD. I'm in Bankstown and I work at Liverpool. So the top of this, it's quite a diverse LHD as well. So just going into it, why southwestern Sydney so interesting, and where do the inequities and disparities come from? You can see that southwestern Sydney, this is at the life expectancy gap. You go across Sydney and you're losing from Campbelltown, which is in the very southwest Sydney, all the way to Bradfield, North Sydney. There's a 13-year life expectancy gap. So just illustrating for you that there is a significant gap and this is going to reflect general health. I'm going to go into cancer as well. This is southwestern Sydney LHD, and you can see here that the area that I work in, 40% not speaking English proficiently. We have a 2% Aboriginal and Torres Strait Islander population, not the biggest, not the lowest either, and we have 60% of patients from the lowest socioeconomic quintiles and 14% regional remote, and that's why that's why cancer equity research took a real hold in the area we work in. This is a table to show to you the diversity of populations in the area that I work in. This is southwestern Sydney LHD, and you can see the different parts of it. We've got very high rates. So in one of the hospitals I work in, Bankstown, 17% are from Arabic backgrounds. In Liverpool, it's about 12%, so quite high. Vietnamese comes up as well at 7%, 20% in Fairfield, 5%. So I work in a very linguistically, culturally diverse area. And just delving a bit more into it, you can see that the area I work in is quite different to the rest of New South Wales. So I showed you the whole map of New South Wales, but southwest Sydney is quite different. So in southwest Sydney, 20% have country birth of father as Australian, but the rest of New South Wales 48%. Vietnam 12%, 1% of New South Wales. So it's a different area. And I suppose as you're all thinking about equity and clinical trials and diversity, in your jurisdictions, what is different about your jurisdiction and what is it? And country birth and mother similarly. And I think a theme that'll keep coming up is that I know my talk was titled Clinical Trial Linguistic and Cultural Diversity, but the intersection with other healthcare vulnerability is really important. So one example is education level. So you can see here, Southwest Sydney, bachelor degree level above 17%, New South Wales 28%. So less university education. Year 12, this is the highest educational attainment. So 20%, year 12 is the highest educational attainment, while New South Wales 14%. So people are finishing school, but not progressing to any higher education. And again, so just to a picture of what it looks like. I suppose what we're getting to is the social determinants of health, which is a big part of CSO as well, is that this is just from the World Health, there's many examples of this. We have a conglomeration of factors where I work, that there are lower rates of education, high rates of smoking, newly arrived migrants, refugee intakes, high rates of speaking language other than English, or low rates of private health insurance, low rates of GP engagement. So that's a bit of just non-cancer, just an introduction to where I work to help you understand why I'm going to talk about all the things I'm about to talk about in terms of cancer and inequity. So just to get everyone's mind in the cancer setting, now you know where I work. This is an example of a patient that I might see, and I have seen patients like this. It's not de-identified, obviously, and what happens with cancer care. So this is Mr. RS. He's a 70-year-old Vietnamese man, and he's migrated to Australia in the 1970s as part of refugee intake, and he lives in Fairfield, one of those areas I showed you. He's come in with a 6-month history of cough and shortness of breath. He saw some different GPs a few times. He's given several courses of antibiotics to no effect. His children work full-time jobs, don't live with him, doesn't own his house. He's got a medical history unremarkable, hypertension, high cholesterol. He's a non-smoker. This is his lung cancer workup. So he had a CT chest, which showed a 3.5 centimeter left lower lobe mass, and he's got enlarged ipsilateral lymph nodes. So the GP referred him to the respiratory physician at the local public hospital. Public hospitals in Australia, like in the UK and other systems, and Canada, I'm sure, or other places with public are under stress. There's increasing an aging population with increasing demands. He was actually seen 3 weeks later. If he had private insurance, it would have been different. It would have been seen in a matter of days, but he was seen 3 weeks. So that respiratory physician saw them, organised an urgent e-bus. Unfortunately, there was difficulty accessing it. So again, another 2 to 3 week. A PET scan occurred pretty quickly, though. That was one advantage. Showed stage 3A disease, and the MRI brain was clear. So the e-bus for lymph node staging occurred due to competing 3 weeks later. Again, theatre time is really precious. A single N2 node positive, but discussed at MDT is suitable for resection. So at the MDT, it's got stage 3A, referred to public cardiothoracic surgery clinic. Again, the public waiting times in the western parts of Sydney are blowing out. We don't have insurance. So even though in Australia we're really proud of our strong public healthcare system, there are gaps where patients are waiting longer. Placed on an emergency list, 5 weeks later, the hospital is full. It was winter, beds were full, and at operation is stage 3C disease. And the post-operative PET scan unfortunately showed stage 4 disease. This has happened multiple times. It's unfortunate when this happens, but it's an example of the way the delays can occur in the cancer journey and why the outcome has been impacted. Just to push this a bit further, we now have multiple first-line EGFR mutant clinical trials. Some of you will know, you might have these trials center, where it's osimertinib plus antibody drug conjugate. So we offered participation via Vietnamese phone interpreter. The face-to-face interpreter was not available. And thinking about high-impact interventions, interpreters are really important when you're thinking about linguistically diverse populations. Their schedule required significant time commitment. And this patient, again, thinking about intersection, he had no transport. If you remember, he was financially not that well off, and he wasn't sure how he was going to fund his transport, and he didn't have a car. The PIS was over 30 pages long, written university level English. Any of you who do trials will know that. And so you're thinking about an elderly man whose English is not great, but who's good for trial to understand the research. So there's no system in place at the cancer service. Some of the more centres in more well-funded areas do have this transport service, unfortunately not in this area. And so he did not go on trial. So I think this is just to just focus your mind that when we think about lung cancer, treatable condition, if it's timely and the outcomes can be quite good, there's variation access to primary care. So there's difficulty accessing the GP. There are less doctors in those areas where the patients live. There's variation access to specialist care in public settings. The public hospitals under huge amounts of stress. There's no private care to offload public hospital. If you look at Sydney, that map I showed you, the western parts of Sydney, the private hospital concentration is far less than the wealthier parts, which is how the market works. But again, the result is the pressure of the public system. And language remains a significant barrier. So just to show what happens a bit more, I've used this slide before in previous presentations, but just think about because when we think about clinical trial equity and making sure there's diverse representation, we've got to be realistic as well. So this is just an example. So Miss Clark is a 50-year-old woman who's developed refractory metastatic bladder cancer. There's a great clinical trial. She meets eligibility criteria. But any clinician will know the number of steps that are required to talk about a clinical trial. Got to break the bad news that unfortunately cancer's progressed. Got to address her anxiety, the carer anxiety, the children, spouse, partner, prognosis, life thing, the limitation standard of care, the reasons why clinical trial is reasonable. Explain, most patients have no idea about clinical research the first time they're exposed to it. There are many misconceptions in the community. Are we making money from them? Am I a guinea pig? Is it regulated? Is it safe? Is it going to work? And a lot of uncertainty. That's one of the biggest things in clinical research. We don't know. And new things are not always good things, but we know that we have seen developments. The time commitment, the randomization is awful to explain. I was explaining today to a patient and they just burst out laughing. The idea that your loved one's destiny is going to be determined on the flip of a coin is maybe understandable to some people, but to people from other cultures, it seems quite unusual. So it takes a lot of work to explain why we randomize, why the control arm is important, and why it may be justifiable to have yourself or your loved one on the control arm. And so a lot of info there. Now change to Miss Nguyen, who's Vietnamese, who can't speak English very well. What happens? It's going to be a disaster. And that's what we face in areas where we work in communities with limited English proficiency. It's going to take at least double the length of time without an interpreter. And we need interpreters on time, face-to-face available, and that's not always available. So you can see here the kind of situation we can find ourselves in clinically in these areas. And the cancer disparities come through. So it's not, these are not just these are anecdotes from my own experience, but I'll show you now how these demographic differences can add up into outcomes. And when we talk about outcomes that matter, we talk about mortality. So you look at, this is from the Cancer Institute. We're very lucky in New South Wales to have a Cancer Institute which tracks data really carefully and produces these reports about equity. So you can see here, I haven't seen these types of graphs before, but this rectangle on the left-hand side of the rectangle is proportion. So it's 20, 20, 20, you can see. And on the right side is proportion of cases. So when you see the slant upwards, you see an overrepresentation of that quintile. So you can see here in women, the bottom 20% are going to make up about 30% of cases. For men as well, and again for mortality. So both incidence and mortality, the most disadvantaged are making up more of lung cancer. And lung cancer is quite interesting. I picked lung cancer because I treat lung cancer, I know about it, but it's clearly a disease where disadvantage can impact your outcome significantly. And I showed you that map of New South Wales and the kind of life expectancy gap. And you'll see this map, this is lung cancer incidence. And you can see those red hotspots. So you can see there, Fairfield, Liverpool, these are areas with the highest incidence. And then Blacktown, so Demi works in Penrith and Nepean, the incidence in those areas which face significant disadvantage, they're higher. And actually the rates of lung cancer are lower in those more well-resourced areas, which is the irony as well. So definitely there's a gap there. And coming to clinical trials, there's data showing that your socioeconomic disadvantage is associated with your ability to enroll in clinical trial. And in Australia, I guess this is what I'm trying to show you, that Southwestern Sydney, New South Wales is a microcosm of these broader issues about access and equity. You can see this data that if you're in the most disadvantaged, you're going to enroll at about half the rate of the least disadvantaged. So there is definitely a link between those. We'll go into those links later. Again, language as well. You can see this is data across the state. It's publicly available. I can share the links with you afterwards. But English speakers make up the majority of clinical trial enrollments. There's a small number and a disproportionately low number of those who speak other languages. So there is clear evidence that there is underrepresentation in New South Wales. And I did acknowledgement of country at the start. And for the audience, the disparities in First Nations population is significant. Again, this is lung cancer data. You can see that a male Aboriginal man is 2.5 times more likely to be diagnosed with lung cancer than a non-Aboriginal man, and a woman is 3 times more likely. And in terms of mortality, 2.8 times more likely and 3.4. So this is a message that I'll keep sending through in this webinar. Is this data is really important, because this is how we communicate to policyholders, communicate to funders, and say, look, this is the data. There's a disparity in outcome. We need to look into why that is happening, what steps are missing, where the intervention lies. So far I've covered Southwestern Sydney and New South Wales. I've given you a case study of how the inequities can play out in my practice and my experience. And I've shown you the disparity data showing you that these matters. So that's the setting for one of the parts of this talk today is this Australian Centre for Cancer Equity. This project started about 2 years ago, where we were, all the clinicians in Southwest Sydney were dealing with this day in, day out, seeing these inequities, seeing people die early, present late, not getting the test, not getting trials. And then there was a groundswell of movement where we thought, all right, maybe there's something we can do about this. Maybe we can advocate for more equity. What can we do? So this is, you can look up our website, hosted by the Ingham Institute. That's our team there. You can see there, I'll just go through the team because it's quite important. Rebecca, who's on this call, is one of our medical oncology fellows. Zayden is actually a cardiologist. He's I'm going on the left there. He has an interest in AI and multilingual communication. Professor Wei Chua is actually the chair of ACE. She's the head of department in Liverpool as well. Shaz Sassali is our program coordinator. Bernadette Brady is a physiotherapist and clinician researcher who's done some groundbreaking work in community partnership. There's myself. Payam he was previously a clinical trial coordinator in the unit. Now he's the program coordinator as well. Dr. Fisaha Tesfaye is our research officer. Associate Professor Tara Roberts is the research director at Western Sydney University. And Hao Tran is a PhD student and a cardiologist with interest in AI. So 2 years ago, there was no one. And now we have this wonderful team. So I'm so excited to present this to you. And we're really, and all of us are running projects focused on enabling high quality, locally driven research with national global impact for priority groups. So our strength is obviously multicultural groups, but we're extending to equity in all types of groups that are missing out. We have 3 core pillars, and one of the parts is that I guess CSO has the vision of equity and accessibility, and realize the need to engage policyholders and stakeholders. And ACE is an example of that. We have partnerships with the New South Wales Health, which is our health service, the Ingham Institute, which is a medical research institute, the Cancer Institute as well. So it's a strong partnership, and we have gathered together and pooled resources to address these pillars. So prevention, early detection and screening, responsive and accessible health systems, and personalized care and precision medicine. Our flagship areas are around lung cancer equity, clinical trial participation, and AI. So that's kind of the broad structure of the research group. And these are our priority populations at the moment: lower socioeconomic groups, culturally linguistically diverse communities, Aboriginal and Torres Strait Island people, mental illnesses come up recently, and rural, regional, and remote Australians. So a couple of just examples of projects that we're doing. One of the, or some of you may be familiar, when you start someone on chemotherapy or targeted therapy, immunotherapy, we provide a patient handout. In New South Wales, we have a wonderful resource called EviQ, but it's only available in English. So there's a project funded by Avant, which is looking at trying to use a chatbot that's multilingual to get this information in other languages. So a really important initiative. Trial Translate is also a funded research where we're trying to, again, you saw my example of the difficulties with explaining clinical trials to patients whose English is not great. So trying to find ways, can we use AI to reduce the length of PISs, to make the research more accessible, to help misinformation? Obviously a very ambitious project, but we need ambition in this area. There will be barrier after barrier after barrier, but we have to remember, we're here to help people get onto research. We're not trying to stop them. We're trying to make it more safe. So that's also an interesting project, because we're getting in pharmaceutical companies, regulatory, ethics at the start. So we don't have an implementation gap at the end. We have a great solution, and suddenly someone's like, oh, can't implement it. I won't go through the EviQ. This is the EviQ project, where that's what we do. And this is a chatbot. I won't go through this, but it's been developed for about 7 months, co-designed with 4 different communities, with input from clinicians, and it's a really, really fascinating project. And this is an example of our team. So a really large group of people now. Sorry, it's so pixelated. But again, part of, as you're doing with CSO, we're trying to influence stakeholders, influence people, encourage people. That's what we've been doing at ACE, where we're trying to help everyone understand the importance of equity in the way we deliver cancer care. This is just a timeline to where we are, and we're still going. We'll go for that. And so, yeah, it's really the Minns Labor government has invested in this research collaboration, and it's been really important to see where we go. Definitely join us, but I'll go through at the end. So about halfway through the talk, so I won't talk for that much longer. So Common Sense Oncology. So Demi was my supervisor from 2019 to 2024. I've known Sam, who's may not be on this call. I've been watching his CSO fellowship work, and Brooke Wilson is actually one of the key members of Common Sense Oncology, and I worked with her as a second year oncology register. So I've always thought about Common Sense Oncology, and but I've not been part of it specifically. But when I look at the guiding principles of Common Sense Oncology, this is from the Lancet paper and the website. These are the kind of 8 principles you're all thinking about. 2 of them really stood out to me. So number 1, access to quality cancer care is a basic human right. No patient should be denied access to effective therapy. Number 7, equity and access to high quality care should be prioritized as much as innovation, new treatments. Those 2 statements really summarize the mission we're doing at ACE as well. I don't think we would, and I think all of us recognize cancer as in an economy like Australia as a human right. And if we have effective therapies, whether it's screening or we know clinical trial participation helps, then that we should really be making every effort to make that happen. And number 7, the equity is really important. I think I was hearing Vishal speak to Declan Murphy on a podcast, and as oncology trainees, we go to ASCO and ESMO, we see these amazing plenary presentations with these new drugs. But then as I got through my training and into consultant, I was like, these are not trickling through. These are not coming through to the patients who need it. So the equity and access hasn't been thought about in advance, and that's not been baked into the system. What is the use of having a fantastic innovation if people don't get it? So that's those two really struck out to. That's why I see some collaboration. So I think Southwestern Sydney, like I've gone through, is a case study. It's kind of a very focal example of what CSO principles might look like. I think CSO is often concerned about the global cancer burden, and I understand that there are many low-hanging fruit that need investment, like radiotherapy or surgery access in low and middle-income countries. That's the real where you could get some real bang for your buck. But I think there is also CSOs also consider variation within high-income countries like Australia, Canada, US, UK, which have significant pockets of disadvantage, like I've just shown you in the area I work in. And I suppose ACE is focused on reducing variation within Australia. Our research group is led by clinicians working in public hospitals serving disadvantaged areas. So we see this reality. And I think if there's any junior trainees out, being a clinician researcher is so powerful because we see the experience and then we can speak to it. I can tell you about that case study because I've seen that patient. And so it's definitely a big need for clinician researchers. And we're local researchers focused on local outcomes. We're always keen to share and learn from other jurisdictions. We face similar issues. And this is an interesting slide. I just put this up that reflecting back on my experience in Southwestern Sydney and CSO and ACE, I think about a few examples of where the gaps are. One of the examples that I've recently come across is zoledronic acid in the adjuvant treatment of early breast cancer. And there's a variation in practice across Sydney. When you have patients in busy public centres, often zoledronic acid is hard to give because there just isn't enough chair time because the chairs are under so much pressure. Compare that to the other side of Sydney where there's private centres or less patients, more staff, more chair time, and it's often part of the package, not even questioned. The time to commence neoadjuvant therapy comes up as well. Often public hospitals will face with that, and so that's again thinking about we know this works, we know we should give it on time, but we're not able to because of the way the system is designed, where equity has not been made at the forefront. I think one of my favorite is I guess for CSO audience as well is the recent study on exercise and the benefits of exercise in the adjuvant treatment of colorectal cancer. The benefit the same as oxaliplatin. And I think there are so many of us in the audience thinking, patients ask me, what can I do to improve my outcomes? I say exercise. And it's like, oh, can you give me a number? It's like, oh, I'm having trouble finding a number. And the exercise physiologist is not easily located. So again, years of work and careful work, Chris Booth and his whole team, trying to get this high quality evidence published. It's published, and then I'm sitting here wondering, how am I going to implement it? Who's going to pay for it? How am I going to access it? So again, a gap. Of course, again, if you have the means and the advantage, you can access it. You can do it. Oncotype DX was a really interesting as well. And again, these are all examples of Australia where we have very good, and I know we have excellent drug funding compared to the Asia Pacific region, at least in terms of access. But there are these areas which are not funded where the gaps still remain. So affording the genomic testing that's not affordable, and again, it has access to clinical trials. And then the really low-hanging fruit is the cancer screening as well. I haven't got the data here, but it's there. There's huge amounts of data showing that the screening rates are different, and that's really a lot of bang for your buck. But there's lots of gaps there as well. And of course, precision medicine and germline testing is a gap. So interesting things to think about in Southwest Sydney. So I'm going to go through some pilot projects. I think in equity, or even in CSO and equity, there's this idea. Do you have solutions? Stop criticizing. What are your solutions? What are your solutions? But solutions can't be developed in 6 months on $2. And they're not going to turn around in 12 months. We haven't worked on this area for many years. A lot of research needs to go into this. A lot of careful communication needs to go into this. We're not going to have solutions tomorrow. So I've called them pilot projects, and I'll go through these fairly quickly, and we'll have some discussion at the end. So I'm going to show you 5 things. The first one is the barriers and enablers paper, and I would encourage strongly not to repeat this. Don't ask people about barriers and enablers. I've done it. I would never do it again, and it's been done before in the literature. This literature is about 30 years old. So there are things you don't need. We know what the barriers and enablers are. Perla is a really good data capture, and this is really, I'd encourage you all to think about how you capture data in your settings. The bilingual navigator I'll talk about, but there's some lessons that we learned there. Cancer Prism is a partnership with the Chinese community. I'll talk about All Clear briefly, and then we'll have time for discussion. This is a 2023, the Barriers and Enablers paper. We interviewed, and Demi supervised me along with my Fran about asking people, what are the barriers and enablers? We didn't talk to patients, we talked to clinical trial coordinators. We had good good exposure around Australia. But this is the kind of barriers enabled. So I've put this slide up. You'll have the slides. You can see it. There are communication, opportunity, mobility, economic, cultural barriers. They're all there. All the barriers are there as to what will prevent someone going on to a cancer clinical trial from a CALD background. So we know, and you can see the most common ones: English proficiency and health literacy. The solutions also, we propose some solutions from the literature, navigators, multilingual pamphlets, patient education videos, identify finding. No, they're all reasonable. Everyone thought they're reasonable. We need to try these out now. And this is just a slide I haven't had to change for quite a few years. But when you're thinking about clinical trials, the best way to think about it, in my opinion, is sponsor, site, and the community. And you can see at the sites need to support to do this equity work, and sponsors need to be careful, not excluding patients, not translating prose, for example, making sure they're making every effort to include, and patient, of course, in terms of community partnership and engagement. And data capture is central, because if we don't measure it, we can't manage it. This is a paper from JCR Spectrum, led by one of our wonderful fellows, consultants now at Liverpool. He was a fellow when he did this work, Udit Nindra, and a collaboration with RAND Scientia, which is a phase 1 center, looking at evaluating patient diversity in early phase clinical trials. And this is an example of what we thought would be best practice in data capture: country of birth of parent 1 and parent 2, and proficiency in English. The data capture around CALD at the moment is fairly poor in New South Wales. We collect country of birth and language spoken at home, which doesn't really tell you about the intersection of different factors. We also collected postcode to have a surrogate for socioeconomic status. But this is what allows us to design our services better. If we just have country of birth, it's not going to really lead to that effort. And the data was quite, most people were born in Australia, which tells you something already. So again, we know it's not CALD, it's more the people who have arrived in Australia recently who are at greatest risk of healthcare vulnerability. I often use myself as an example. I was born in Australia. I am Indian. And again, I don't have the same disadvantage as someone who just came from India 5 years ago. But the word CALD puts us in the same basket. And policymakers should not see myself and my counterpart who just came here in the same basket. We have different needs. So it's really important to capture that data. Where were you born? When did you come to Australia? I think that's the most important part, because that shows you how they can engage. So careful, thoughtful data collection that's relevant for your jurisdiction and your level of control is really important. And this is what we thought. And ethnicity is so interesting, because if you look into ethnicity literature, this is a big problem. And I was on another call recently, and I said, ethnicity is about what you choose to identify as. And I said, some days I feel Indian, and some days I feel Australian. It's a really complex concept to capture. But biologically, when we think about pharmacoethnicity and thinking about metabolism, I suspect parent 1, parent 2 tell you more about someone's biology than necessarily their ethnicity, which is very complex, especially in multi-layered, multi-generational societies like Canada, US, UK, Australia. This is our first grant. This was for Arabic Navigator, and this was about $50,000. And we were looking at trying to improve recruitment of Arabic patients onto clinical trials. And we asked doctors, why do you have trouble recruiting Arabic-speaking patients? The word trial sounding like experimentation, challenges with interpreters, and time. So it's not like we don't want to, but this is the nature of structural racism, where you just are not the system does not allow fairness. The system does not allow it. So then you get a clinician saying, I don't have time to do this, because they haven't been given the time to recognize these patients need more time. We asked patients as well, and this was so fascinating. And when we find, this always gets me that, in Syria, the cancer doctors don't tell the patient there's cancer. He gave me 3 options, and then he made the recommendation of what he thought was best for me, left it for me to decide. The things we prize in Western medicine about autonomy, consent, voluntariness, these are culturally bound concepts. Clinical trials are culturally bound concepts in Western worlds, where it makes sense to be like, I will make the decision to take these risks and be part of this trial. But that's not how other cultures work. With them can be more collectivist, where decision making is more diffuse, and autonomy is not expressed in this kind of individual method. This is the photos. This was community partnership. I know CSO and patient advocacy is really part of it, but this is a great example of how the health service, researchers and clinicians and the community came together. A lot of work, a lot of trust building. This doesn't happen in 2 months. This takes time. I won't go through that. And this was the BTN consultation structure. So basically, we trained bilingual community educators to deliver cancer education to Arabic-speaking patients in their language. And we realized that cancer literacy precedes research literacy. So if people don't understand cancer, they're not going to be part of your phase 3 RCT. And we realized there were so many gaps in cancer. What's a biopsy? What's a PET scan? What's a biomarker? This is really complex. For us who live and breathe this, it's maybe not complex, obviously, but for patients who've never come to cancer before, they're faced in this whole world. Why would I be part of a trial? Doesn't make sense to them. So that was the idea. So we surrounded the patient with, there's the interpreter, the coordinator, and then also there's a navigator as well. And this was the structure of the navigator. And this is our team. So there was the care coordinator, a researcher, and on the bottom row is the 5 community educators. So this was, again, an example of a partnership between the health sciences community. We've done a similar program in the Chinese community. So you can see here, this is in southwestern Sydney. This is Professor Wei Chua discussing genes and biomarkers. So you can see the pamphlet, it's in Chinese. The patients have come in to the center to learn about it. So this kind of bilingual partnership is what ACE is really proud of and we're still doing. We did another one last week, which was about clinical trials. Some of you might know Chi Li and Winston Liao, so big prominent trialists, trying to get into the community and showing what they do and why they do it. Chi spoke about the white mouse syndrome, the guinea pig mentality, because we knew from the community that's what they were worried about. So he went through it with Chinese translation, with interpreter present. This is the kind of partnership we imagine. It hasn't been done before, but we're trying to do it because we know this was what's going to help ultimately with participation and sharing this. I've spoken at Ping Sai, which is a South Asian group. And finally, I'm part of the All Clear program. This is just a bit of step different. This is a $25 million research grant from the National Breast Cancer Foundation. And you can see Christine Schaefer and Peter Croucher lead that, along with Fran Boyle, John Locke, and Marianne. And Marianne is the leader for Workstream 5, which has a percentage of the funding, and it's just about equity and diversity. So in this big team of scientists and researchers and a whole lot of people, there are people who are dedicated to equity diversity. So I was able to put this slide up at their symposium where I said, we need to aim for these targets. That's another example of how equity can operate in big research programs to ensure that we keep serving the people we need to. So last couple of slides, zooming out, there's an editorial here. So just zooming out. So I just zoomed into various community partnerships and then zooming out what's happening at a broader level. There is definitely structural racism and inequity in how cancer clinical trials operate. Where are they located? And inequity is kind of baked in. And there was in response to a big paper of 250,000 people in California looking at the way barriers result in lower trial participation. Research inequity remains the canary in the coal mine. It's downstream cancer literacy. And so it remains like a luxury product for our cancer patients. It's like business class. But if you're not doing really well, you're not going to get to the trial. And if you are doing, if you average treatment, you're not going to get to a trial at all. So fine. The last couple of slides, just a bit of reflection, is that, and what something we've worked on, culture is not just language. Modest, this autonomy is really kind of culture bound, and courage and fighting, they're very Western kind of bound concepts. These values are not universal. When is it okay to just flip a coin and decide your fate? I don't know when, but we have to do better in explaining it. Susan Sontag, illness as a metaphor, we have a lot of metaphors around cancer that are part of our culture, but not part of other cultures. But to keep that in mind, our goal is not just to have more imperialism and say, be like us, join our trials. And this is a photo of, I'm not, at the award that we won. This is the Premier of New South Wales awarding this equity award. But just to give you the idea that we have moved equity up the agenda. I'm on the same stage as basic science researchers, clinical researchers, so equity is there. And I think all of you in the CSO positive environment can move equity up the agenda in everyone's eyes. Acknowledge a very large team of people I work with, and thanks for listening.
Thank you, Abhi. Amazing talk. While people are thinking of questions, I might just try and share the CSO slide so people can, hopefully you can see that, know where to join CSO. So you can work with people like Abhi, but also the rest of the Common Sense Oncology group if you want to join our movement. Before I'm very happy for other people to put their hand up and ask questions, but if there are none immediately, I'm happy to ask one. But does anyone want to ask Abhi a question? Feel free. Everyone's always very quiet. Abhi, maybe I can. Is there a hand up that I can't see? I'm not sure I can see everyone on the screen. So anyway, Abhi, maybe I'll start if that's okay. I know obviously it's this. Uh, there are so many barriers, but also a lot of potential solutions to improving equity to access, particularly to clinical trials. If you could, had unlimited resources, magic wands, and wanted to implement one or two things tomorrow, what would you choose to have the biggest impact immediately?
I think I would mandate equity as part of clinical trial site accreditation. There's always an effort to do that through our National Clinical Trials Governance Framework, but overseas, the NIH mandated minority recruitment to maintain comprehensive cancer center accreditation. And that kind of stick did encourage the broader community to take notice. I think the carrots don't work so well. I think equity sounds nice and fluffy, but it doesn't get people out of their chair. So regulatory levers would help. And I think we're going towards that, absolutely. So we had accreditation recently that said, what are you doing to improve equity? But I think, again, getting some teeth behind that would be good. I think more celebration of trial centers that are doing well for equity, more dissemination would also be encouraged. But that's where I'm at my current thinking.
Does Australia have any? So at the moment, if you're running clinical trials in Australia, there's no mandate or requirement to necessarily include people of culturally and linguistically diverse backgrounds.
No, and I think this is quite relevant to CSO. The clinical trial agenda is set by US pharma, and US companies set the agenda for protocols and projects. And so their KPI is the FDA minority recruitment. So they'll often ask our Australian patients, are you Black? Are you Hispanic? And then we, as Australia, we're such a small place, we're 25 million people. And we cut these protocols trickle down to us. And that's all we're doing. So in terms of championing equity at an Australian level, we've got to do it at the site. We can't rely on sponsors to do this. And they don't, we don't have to change the whole system, but each site can champion equity. That's what I've always thought. That every site can think about who's missing out and just being local. And I think it's so easy to become nihilistic in this space, say it's too hard. But all of us at site can definitely try and think of ways to improve equity locally.
Go on. Hey, Chris, go ahead.
Sorry, amazing talk, Avi. That's amazing. Chris Brown, I'm a statistician at the University of Sydney. Just thinking from the design perspective, and I think what you said about the trials was amazing, and treatments from that perspective of trials, like you mentioned some wonderful examples where it's, even though we know a treatment is effective, it's hard to implement. Is the trial setting different? Like, is there anything we can do from the trial perspective to make the logistics easier and facilitate that even after we've identified the right sites to help with this? We have to solve the logistics problems for you as well.
Thanks, Chris. That's a really good question. And it's an interesting, this gets to the heart of the problem. So clinical trials are highly complex, need highly trained investigators and a highly structured environment to run them safely. All researchers put safety right at the top, and that's where it should be. And then the question is, often the areas serving diverse populations, disadvantaged populations, are often under-resourced places. And they often haven't had the key opinion leaders that keep getting the trials working there. So how do we find a way to boost up these less resource sites to run trials safely and to feel safe doing that? And I think that's actually government. So that's where government can redistribute resources and say, look, we want to have high quality research. We need to invest in these areas. And that's why the policy advocacy part is so important. Otherwise, the trials keep going to the big centers. And if you're not lucky enough to live near a big center, you miss out. I think decentralizing trials is such an important movement as well. And so many people, I know AGITG is trying, Sabe Sabison's been trying, but to be honest with you, it's very slow. It's been hitting so many roadblocks. And every conversation I'm in is roadblock, roadblock, roadblock. But the sooner we decentralize and recognize that community oncologists and others can run trials safely, the more equity there'll be. So there's two parts to that. And I think it's going too slow for patients who are living in these areas now.
Thanks, Chris, for that question. I'll read out Bridget's question, then we'll go to Sarah, who's got a hand up. So Bridget's asking, she said, great presentation, but she also said, research has identified several solutions to cancer inequities in your work, obviously. but have you seen a genuine appetite from New South Wales Health Services to make real structural change? I feel like I'm about to be triggered, but please go ahead, Abhi, and answer the question.
This is a tricky question, I guess. I don't know if New South Wales Health is online.
let's presume they're not.
Yeah, look, I don't know. I don't know. I think it's I think the problem has only been recently articulated, and I think it does in public health. It does seem the squeaky wheel gets the grease. So the more noise we make, the more we cry, the more we kind of yell about it, the more likely that change is going to happen. I think it's generally there's goodwill at leadership, but again, there's so many competing priorities. And one of the things that recently come up is clinical trials is part of clinical care, and not separating the two has been a useful kind of construct to help us keep advocating for more resources, that research is part of high quality care. And I think I've met so many people within New South Wales who are really motivated to it. I wish there were more people, which is probably where I'll end my sentence.
Yeah, thanks. Sarah, do you want to ask your question?
Hi, Arby. Thanks for an excellent talk. I'll try not to ask anything too pointy after that one. I've got two questions for you. I was really intrigued to hear about the Trial Translate project with the chatbot as a self-confessed Luddite, but nonetheless open to things that improve access, etc. Just wondering, is that intended to be a generic type of tool that you could apply to any given trial in a real-time sort of basis? Like if I was seeing a patient in my centre, then I could apply that to help translate trial paperwork or PICFs for a patient, or in some other way. And yeah, just interested how, like, do you anticipate that will sort of be able to get through ethics sort of in a generic way as part of consent processes, or it'll be a reinvent the wheel with every single trial that you would try to apply it to type of situation? That's question one. And then question two was some of the stakeholder research that you've done with different communities, and some of the comments that you made about, I guess, perceptions around clinical trials and myths around clinical trials in different communities is really interesting. I'm just wondering whether the Cancer Equity group has any plans to, I guess, develop some kind of like central resources that could be disseminated to communities, because it strikes me that for those of us who are working with particular cultural groups for whom this might be a barrier, maybe sometimes there's a role for dispelling sort of myths in a generic way, as like the sort of groundwork before you actually get to the specific trial that you're trying to introduce. Thanks.
Thanks, Sarah. The first question, Trial Translate, great question. You picked up the nub of the problem. And I thought about this exact point. And what we're going to do is going to have a generic research kind of chatbot we're imagining, and that's multilingual. So what is research? What is a trial? Am I a guinea pig? Who owns trials? Who gets paid? Can I withdraw? So a generic, and basically GCP. I looked at the GCP brochure and I was like, if I could make this patient facing to explain to patients who don't trust the amount of regulation that goes into clinical trials, that might go some way to dispelling myths, and if it's in their language. Secondly, the much thornier problem is the PIS. And I think the amount of regulatory problems there is enormous. And what we're going to do is proof of concept. At the moment, the status quo is that no PIS is ever translated because it's too expensive, because it's not accredited. And we can't allow the status quo to keep hindering accessibility. Because what we're saying is like, all right, here's an English PIS, that's 30 pages, and this is the safest thing we can do. We can do better. We are going to do better. And one method is are we able to use a large language model to accurately and safely translate a PIS to a sufficient level of accuracy in a reliable way in a particular language, that this system can be used for the sponsor to rapidly produce translations at the point of trial entry. So that's the kind of thing. But you're right. I think the generic research chatbot will be able to get up pretty quickly, but this trial specific, the way the kind of complexity and bureaucracy of clinical trials is such that I think I'm a bit more pessimistic. The second question, myths and barriers. We're definitely going to share resources. I think each community has different ideas. I was at an Indian event, and the talk before me was on Ayurvedic medicine. So there was a doctor who was speaking about ghee and sugar and holistic ways, and then I came on talking about RCTs. And I think one of the things we've realized is that there's different ways of thinking. That there's, and also in first instance with bush medicine. So we have to be serious when we go partner with communities and Chinese medicine. The different ways of understanding the world and health. That's what I meant by the cultural imperialism. Like, all right, well, this is how you're thinking. This is how we're thinking. I wonder if there's a way that we can meet somewhere in the middle. Otherwise, we'll just keep hating each other.
Excellent. David didn't have a question, but he was just reflecting that different cultural populations report toxicities differently, which is, I think, a really interesting reflection and worth thinking about. And you probably already answered Sheetal's question in some way, but feel free to expand. They're asking how can future health technologies improve clinical trial access for small multicultural refugee communities in regional New South Wales. So a lot of barriers there to trials access. He or she's thinking of the Congolese community in Albury-Wodonga. Are there other? And you mentioned the chatbot, which sounds really interesting. If you can dispel those myths, that get that information to someone in their own language. Are there other sort of technologies you think that are coming along that could help?
Yeah, great question. Thanks, Sheetal. I guess one of the interesting things about AI I've recently learned is that there's inequity in AI. Large language models are not fair. They do some languages better than others, and I have a feeling Congolese is not going to be high up on the LLM accuracy list. So it won't be. We can't use the same solution for that. One of the things as a trialist, clinical trial consent is about trust. I don't know how many patients really understand what we say. Even what they see is a caring doctor who recommends research and they trust. So I think that's what trust is so important. And I think I don't think technology is the answer to everything. I think in that community, we're trying to find how to build trust between the healthcare service and that community, and that would be the bedrock of that partnered healthcare where you get equitable outcomes. I mean, technology is great, but I think it's got its place and its purpose, and I think trust is still primary.
Yeah, I think that's a really good reflection. There's a few more minutes, so maybe just one more thing, because I know you've done work on it, and I'm still fascinated by the idea and I think we should push harder for it. Is you've talked about how patient information consent forms are 30 million pages long, and no one ever really reads them anyway. And someone with English not as their first language is almost certainly not going to understand any of it. Do you think we can move towards a much more simpler consent form? Because I would imagine that would be reduce the barriers to access for some people of particularly linguistically diverse backgrounds.
I think we can, Demi, and I think we can do better with enough effort from investigators. And that's one of the benefits of AI. You've all used large language models where you say, make this accessible to a 12-year-old. And I think that it summarizes, condenses it. And the ethics kind of regulatory jumping up and down about, oh, you've lost all this information. Hold on. Do you realize that no one ever reads any of that information? At least they're reading something. So we have to keep committing to that patient-centered vision that communication is two-way. Did you understand what I said? Did have you been able to read this? And if they can't, so I think AI can help. And a lot of our work for PAL communities apply to low literacy communities. I think you look at the average level literacy across Australia, it's like 50%, and I think it's like a year 12, year 10 level or below. A lot of people are not able to process these really complex documents, and we can do. And someone just put up I was about to say CTIQ has put up a better template, so there is change. I mean, ideally, it's a video or an animation or some patient-friendly way of communicating all that text. Yeah.
Excellent. Thanks, Janelle, for putting that up. Maybe I'll just give the last question to Jacob. He was pointing out that Australia seems to be far ahead in the researching equity in cancer world, and particularly CALD populations. But I guess he was wondering, are there any other working groups and organisations globally that are working in this space and to exchange ideas? Because I'm sure what he's getting at is that there are probably lots of ideas out there and cross-pollination of those thoughts and solutions to all the barriers we face might be useful.
Yeah, I guess I spend a lot of my time thinking about this area. There's a group in Bristol led by Shoba Dawson and Sean Truick, which looks at clinical trial diversity in primary care research. we recently met one of the Orkney collaborators who was in St. Louis, looking at the Black community engaged in breast cancer screening. There's a nursing center in Canada, but there is no central kind of coordination because this is the global cancer equity issue. And that's why I was very clear, because our mission is local equity in Australia, because the challenges in different areas are so vastly different, but there are shared lessons. I think Common Sense Oncology, they're probably a home where we're all thinking about this together, but I can't think of a forum where but there's definitely lessons to be shared as well.
Yeah, great. Maybe it's 2 minutes to 8, so we might finish up there. I think it's been a wonderful talk. I think, I hope the CSO community appreciates the work you're doing because it definitely falls within its vision. I think we can all do better at making sure our patients get more equitable access to clinical trials and better cancer care in general. So I appreciate the efforts you're putting in this space because I think the work you're doing, although it's very Australian focused in many ways, has global application. So thank you again for your talk and your work.
Thank you, Jamie. Thank you everyone else for attending.
Good evening, everyone. Thanks for joining.